Ladies and gentlemen, dear friends, what pleasure to have you today with the European Society of Gynecology webinar. First of all, you have seen that we have announced that our next Congress, the 16th Congress of the European Society of Gynecology, will be held in Riga, 9 to 22 of March 2025. Then we are sure that we will enjoy all together of this fantastic event. And I thank you today of being with us with that webinar on thyroid and reproduction. It's a very important chapter of our daily practice. And we have two masters today. We have Professor Sophie Christin Maitre from Paris and Professor Andrzej Milewicz from Wrocław. Professor Sophie Christin Maitre, she will speak about subclinical hypothyroidism in the context of infertility and pregnancy. Thank you, Sophie, for being with us. And she is the head of the endocrine, diabetes, and reproductive medicine in Saint Antoine Hospital in Paris. And since 2003, some years ago, she is the full professor of endocrinology at Sorbonne University, and she is part of the board of the European Society of Gynecology. And after her, Professor Andrzej Milewicz, I will introduce him after. Then, Sophie, you have your microphone. You can share your screen for your presentation on subclinical hypothyroidism in the context of infertility and pregnancy. Thank you, Sophie, for being with us.
Thank you, Andrea, and thank you, everybody, for being here. Ladies and gentlemen, it's a pleasure for me to give a talk on thyroid dysfunction and pregnancy. So first of all, what is the prevalence of thyroid dysfunction during pregnancy? Well, if we look at hyperthyroidism, it can be transient gestational hyperthyroidism, 1 to 3% of all pregnancies, or Graves' disease, 0.4 to 1% before pregnancy and 0.2% of women during pregnancy. If we now consider Hashimoto hypothyroidism, it's 0.3 to 0.7% of all pregnancies. But today's subject, subclinical hypothyroidism, is much more frequent, as it is 2 to 18% of all pregnancies. Therefore, this subject is very important. So we are going to touch upon the definitions of SCH, its impact on fertility, on the pregnancy outcomes, on the fetus and the future child. Then we're going to see whether there is an impact of thyroid hormone treatment in patients with SCH desiring a pregnancy. And finally, very practically, who should be tested for thyroid function before pregnancy? So there are different definitions of subclinical hypothyroidism. Once we should consider before the pregnancy. If we consider before the pregnancy, the most prevalent definition is a TSH level between 4 to 10 milliIUs per liter with normal T4. And that's the most appropriate definition. Some groups or some association consider TSH between 2.5 to 10 milliIUs with normal T4. But this is now not the reference one should consider for nowadays. And finally, in case of positive anti-TPO or thyroperoxidase antibodies, a TSH level between 2.5 to 10. During the pregnancy, well, it might be difficult to give a diagnosis of subclinical hypothyroidism. It can be TSH higher than standard deviation on at least 2 measurements within 6-week interval, or, and this is much easier to remember, TSH higher than 4 milliIUs anytime during the pregnancy. So the level of 4 is really to be remembered. So on this graph, I just would like to remind you the importance of the T4 level on the fetal dependency on maternal thyroxine. This graph shows the HCG level during the pregnancy, then the normal evolution of a slight decrease in TSH at the beginning of the pregnancy, and of course the increase in T4, which is very, very important for the fetus, especially during the first trimester of pregnancy. So last year, in 2023, the Journal of Clinical Endocrinology and Metabolism published a very important paper entitled TSH and free T4 Reference Interval Recommendation and Prevalence of Gestational Thyroid Dysfunction. And this is very important as it illustrates how the variation of TSH and free T4 level over the pregnancy. So I mentioned previously that the prevalence of SCH is 2 to 18% of all pregnancies, according to the chosen definition, but also according to the country, because as you can see here, it's less frequent in China, 4%, and much more frequent in some countries in Europe, with 13.7% in northern Spain. And the main etiology in Europe is chronic lymphocytic thyroiditis, by position in some countries where it's more iodine deficiency. But the majority of Europe are countries with slight iodine deficiency and not severe iodine deficiency. So what are the known impacts of SCH on fertility mainly? Well, I would like to mention this very important study published in the JAMA in 2022, evaluating the time to pregnancy in a huge cohort of women from China. And the time to pregnancy was the first evaluation, and the second endpoint was the rate of spontaneous abortion before the 28th week of pregnancy. Women included in the study were between 20 to 49 years old, and the TSH level had to be measured in the year before the pregnancy. And here are the results. So this is a huge study, including more than 11 million women with a mean age of 27 years, desiring a pregnancy. And as they were followed upon, 42% started a pregnancy within 1 year. Their median TSH was 1.73 milliUs per liter. And interestingly here, you can see that the number of women with TSH higher than 4 was roughly 3%. The majority had normal TSH level and some had low TSH level. And they actually evaluated the fecundability according to the TSH level measured before the pregnancy. And the reference was, of course, 0.37 to 2.5 or 2.49. And you can see that it's a U shape. And you can also see the results as this curve showing a correlation between the preconception thyroid TSH level and the hazard ratio of fecundability. Therefore, the higher the TSH is, the lower the fecundability is, and therefore the time to pregnancy is longer. Now looking at spontaneous abortion, well, the same reference between 0.37 to 2.49, you can see that it's very statistically significant. If the TSH is higher than 4, then the spontaneous abortion rate is much higher. And this is another way to show the results
with a preconception TSH level and the odd ratio increasing of the risk of spontaneous abortion. Therefore, there's a correlation between a high TSH level and the time to pregnancy and the spontaneous abortion. In this study, the fertility was the highest for TSH between 0.37 to 2.49. And this, there's a same group from China published a year later in Fertility and Sterility, the fecundity on a community-based cohort study. And this curve actually shows the fecundability odds ratio according to the TSH level. And here the TSH was between reference was 0.5 to 55. And in this study, there was no statistically significant difference concerning the time to pregnancy if TSH was below 2.5 or TSH between 4 to 6. So you see that according to the study presented, sometimes it's 4 or maybe even 6. So the one should remember, actually, women should not be higher than 4. Now, what about the pregnancy outcomes? So there are different studies, and I would like to present this one, also a Chinese study, looking at the risk of adverse pregnancy outcomes. And this is on the left, the preterm birth, small for gestational age, birth defects, and perinatal infant death. And you can see that if the TSH is higher than 4, maybe, let's say 4.88, you can see that the odd ratio is higher for everything except the birth defect, as compared to the reference range 2.5 to 4.87. And now an interesting data is the risk of gestational hypertension and preeclampsia. And in this study published in the Lancet, you can see that actually the risk of gestational hypertension is higher in case of subclinical hypothyroidism, although it's not significant because it's only a tendency, because it crosses the one level. But the risk of preeclampsia was higher, and this is statistically significant. It was higher than in the women with a TSH level in the euthyroidism range. So in case of subclinical hypothyroidism, it seems that there is an increased risk of preeclampsia, and the odd ratio is about 1.54. One can ask the question, what are the potential mechanisms involved? And there is no real answer to this. It might be increased anti-androgenic proteins like placental SFLT1, and this increased SFLT1 could induce an increase in TSH. This is an hypothesis, although it needs to be confirmed. What about the impact on the fetus and on the future child? Well, everybody knows now, and I've put this graph, this figure showing and illustrating the role of thyroid hormone in human cerebral cortex development. And one knows that the thyroid hormone and the receptors are very important in brain development. So is there an impact of SCH on the brain of the children? And some studies, also from China, published in the GCUM last year, is called the Shanghai cohort, looking at more than 4,000 pregnant women. They had measurement of TSH, free T4, and anti-TPO antibodies at 12 weeks of pregnancy, and their children were evaluated at 6 months of age and at 24 months of age. And the evaluation was having a questionnaire, both social emotional questionnaire and scales of infant and toddler development. And those are the results. Maternal SCH in this study was associated with a 6.5 point decrease in the social domain and emotional domain in boys at 6 months. And in this study, they also showed a 7.4 point decrease in behavioral adaptation domain in boys aged 24 months. Therefore, it seems that SCH has an impact on the brain development and the the behavior of boys aged 6 to 24 months. Another illustration is from the Generation R study from Rotterdam, the Netherlands, published in the Lancet, where women had TSH measurement before 18 weeks of pregnancy. And in this study, it was a brain morphology that was evaluated by MRI at a mean age of 9.9 years. So the children were nearly 10 years and they had an MRI. And what is shown here in this in those figures is that according to the TSH level, and you see here between 0 to 5, there is actually a correlation. And if the TSH is higher, there's a decreased mean volume of gray substance here on the top figure, and there's a decrease in the mean cortical volume in the figures showed here. So it seems that even slight elevation of TSH has an impact on the volume of the brain of children aged 9.9 years old. And finally, there's this study published also last year evaluating 292 pairs mother and children from northern Finland birth control cohort with a mean age of 20 years old. They also had, those were much elder because they were 28 years, and the MRI was measuring the white substance. And here you also show a correlation. It's with free T4, but there's also a correlation with TSH between the level of white substance in adults 20 years old, according to the TSH of their mother during the pregnancy. However, I would like to be cautious, because what are the real meanings of such variation? We are just starting to evaluate them, and the demonstration is still a little bit light to make definite conclusions, but it seems that the higher the TSH level is, the more impact, potential impact there is. So next, so we have shown some effects. And the next question is there an impact, or are there impacts of thyroid hormone treatment in patients with SCH desiring a pregnancy? Is there a benefit to treat those patients? So this is a study looking at pregnant women treated with LT4, so L-thyroxine, for at least 6 months before conception. And it was published several years ago. It was in GCNM in 2014. And you can see here that according to the reference, if the TSH level is still high, definitely if it's higher than 10, then there's a higher risk of miscarriage. So this graph shows that although they are being treated with LT4, they are not all below 4. So it means that the treatment was probably not totally well adapted. But it shows that if the range was below 4.5, then the risk of miscarriage was the same as the reference. So therefore, one can extrapolate that probably normalizing the TSH could have a positive impact. And a very recent randomized systematic review and meta-analysis of randomized controlled trial has been published in Thyroid last month. And if we look at the live birth rate, then actually compiling all the studies, it seems it's not significant. Therefore, it's not exactly the same results as the one I presented just before this slide. So it's a Japanese group. They actually compiled all the randomized study. And this is a very important point because some studies were not randomized. So therefore, to make the proof, it has to be randomized. And looking at the miscarriage rate, here you see also that if the TSH is higher than 4, then of course the miscarriage rate is higher. But if the TSH is within the normal range, there is not an increased risk of increased rates. So there's a question remaining. Is preconceptional thyroxine treatment for TSH level higher than 4? The majority of the studies say probably yes, but some randomized study say maybe no. So it's still a debate whether the TSH level should be decreased to a level lower than 4. And very recently, this month, last month, May 2024, the American Society for Reproductive Medicine published in Fertility Sterility a guideline looking at subclinical hypothyroidism in the infertile female population. So this is the subgroup of infertile patient. And their recommendation is, it's quite strict. It is not recommended to treat pregnant women or women desiring pregnancy who have a diagnosis of SCH with L-thyroxine, as treatments have not been demonstrated to reduce pregnancy loss, nor to improve clinical pregnancy or live birth outcomes. So the strength of evidence is only B, and the strength of recommendation is moderate, but the statement is quite strong. And another statement is that L-levothyroxine therapy for SCH diagnosed in pregnancy is not recommended for the indication of improving developmental outcomes. So I showed you some results about some tests, some developmental tests, some MRIs, but so far, the American Society of Reproductive Medicine says it is not recommended to start treatment to improve developmental outcomes. So this is quite new because it was not recommended so far until this May. And finally, who should be tested for thyroid function before pregnancy? Well, many societies use a targeted approach. A targeted approach, you should measure TSH in women with known autoimmune disease, of course, type 1 diabetes, Addison's disease, vitiligo, or polyrheumatoid arthritis, with psychiatric disorder, with a family history of thyroid disease, history of neck radiation, history of prior thyroid dysfunction of surgery, signs or symptoms of thyroid dysfunction, palpable thyroid abnormalities on examination, and it was mentioned, infertile patient or patients having ART. So this is the actual recommendation that is given by the American Thyroid Association and the European Thyroid Association. And it's also for women elder than 35 years old. So every woman more than 35, she should have a CSH level before the pregnancy. So actually, this is not quite what the ASRM Society is saying because here is their recommendation. So you can see some discrepancy. Thyroid, TSH hormone and T4 levels should be tested in patients with signs or symptoms of hypothyroidism, including irregular menstrual cycles, rather than in all patients with infertility. So the strength of evidence is B and the strength of recommendation is moderate, but it is not at all what the societies for thyroid disease are actually mentioning. So what's interesting is very recent studies try to evaluate what are the risk factors for thyroid dysfunction in pregnancy, because this is very interesting, is how could we actually identify patients with thyroid dysfunction before their pregnancy? And here you can see that parity is a factor of decreasing risk of subclinical hypothyroidism. Therefore, it's statistically significant. The more children you have, the less subclinical hypothyroidism you're going to have. Maybe because you're going to have real hypothyroidism rather than subclinical hypothyroidism. Looking at pregnancy through IVF, you see it's not different. There are no more subclinical hypothyroidism in women having IVF. On the contrary, maternal age, as a woman increase in age, the risk of subclinical hypothyroidism increases. It's statistically significant. This is the reason why women aged more than 35 should all have TSH level. In some recommendation, it's sometimes women more than 30, but definitely for women more than 35. And finally, looking at the status of antibodies and anti-thyroid antibodies, the TPO antibodies, of course, having positive antibodies increases the risk of subclinical hypothyroidism. But everyone knows that a woman with positive thyroid antibodies should be tested every year for her TSH level, especially if she desires a pregnancy. So in conclusions, I would like to give some statements. It seems that optimal preconceptional TSH level should be below 4 milliIUs per liter. In most studies, there are correlations between TSH level higher than 4 and time to pregnancy, risk of miscarriages, and preeclampsia. Thyroid hormonal treatment, I think, should still be given, although I'm going against the American Society of Medical Reproductive, if TSH is higher than 4. Thyroid hormone treatment should be discussed if the TSH is between 2.5 and 4 with anti-TPO antibodies. And if the woman is doing IVF, ICSI, or if she had previous miscarriages, and if the TSH is between 2.5 and 4, there's still a discussion whether the hormonal treatment with thyroid hormone should be started. So thank you for your attention, and I hope I have answered all the questions you could have about preconceptional TSH level and who to treat and who to test. And I thank you very much for your attention, and I will be happy to answer your questions.
Thank you very much, Sophie. Thank you for that beautiful lecture. Even though the American Society of Reproductive Medicine latest publication, they put us in a lot of questions. We will discuss that one later on. And then now it's my pleasure to announce the presentation of Professor Andrzej Milewicz on impact of hyperthyroidism in reproduction from diagnosis to therapy. Andrzej Milewicz is Professor Emeritus of Medicine and Endocrinology at the University of Medicine in Wrocław in Poland. He was invited speaker in several European and international congress in endocrinology and the EFIS, European Society of Endocrinology, and ISG courses, member of the board of several societies. I remind is a member of the board of the International Society of Gynecological Endocrinology, and is also treasurer of the European Society of Gynecology, and is honorary member of several endocrine societies all around Europe. Andrzej, thank you very much for being with us. He will speak about the impact of hyperthyroidism in reproduction from diagnosis to therapy. Andrzej, you have the microphone. Thank you.
Thank you, Andrea. Thank you for his introduction. First of all, I would like to thank you, Professor Giannazzani, for the invitation and give me the possibility to be with you today. So, however, hyperthyroidism is not so frequent like in hypothyroidism, but still creates some problem in our everyday practice. So I have no financial relationships to disclose. And according to thyroid dysfunction, so Professor Maitre say many very interesting information, and thyroid pathology might interfere with pregnancy outcomes. Therefore, all women with thyroid disorders that are planning for pregnancy should ideally receive preconceptional counseling to review their thyroid function. It has been shown that previous studies that hyperthyroidism can be found in about 0.2 to 2.7%. Is much more lower like hypothyroidism, as I told you before. So thyrotoxicosis, this hormonal storm which we observe during the hyperthyroidism, is a hypermetabolic condition, and thyroid hormone are elevated with or without increased thyroid hormone synthesis. But we must say that the most important information is that we, as a doctor, very often prescribe too high dose of levothyroxine, and is a iatrogenic hyperthyroidism because the dose of levothyroxine is too high. That's the most frequent reason of thyroid toxicosis. But of course, we can observe also in subacute thyroiditis, and according to clinical form of hyperthyroidism, we can observe three different phenotypes. Diffuse toxic goiter, Graves-Basedov disease, with autoimmune background, toxic multinodular goiter, Plummer disease, and as a third, toxic adenoma. According to Graves-Basedov disease, is more prevalent in women than in men, with estimates suggesting that the effects about 0.5 to 2% of the general population. It's a typical view of patient with Graves' ophthalmopathy and big thyroid gland. So the second form, toxic multinodular goiter, tends to occur more frequently in older individuals, particularly those over the age of 60. The prevalence increases with age, and it is more common in the region of iodine deficiency. And third one, toxic adenoma. We can expect it in 5 to 10% of hyperthyroidism cases. It's a much more frequent cause of hyperthyroidism which we observe. Toxic adenoma are more commonly observed in older individuals, particularly those over the age of 60, and they tend to occur more frequently in areas with iodine sufficiency rather than iodine deficiency. So, common sign of hyperthyroidism and thyrotoxicosis is tachycardia or atrial arrhythmia, systolic hypertension with white pulse preserve, warm, moist, smooth skin, hand tremor, muscle weakness, weight loss despite increased appetite, reduction in menstrual flow of oligomenorrhea, nervousness, anxiety, increased perspiration, heat intolerance, a hyperactivity, and a heart palpitation. So it's also some variant of thyrotoxicosis in young patients tend to exhibit symptoms of sympathetic activation like anxiety, hyperactivity, and tremor. Older patients have more cardiovascular symptoms, dyspnea, atrial fibrillation, and unexplained weight loss. But in contrast, patients with Graves' disease often have more marked symptoms than patients with thyrotoxicosis from other causes. Especially for typically for Graves' disease is a Graves' ophthalmopathy, which you can observe on that graph, and Graves' peritibial mixed edema, which is also typical for Graves' basal of disease. Elevated hormone levels associated with subacute thyroiditis may occur as part of post-viral syndrome, like a subacute granulomatous thyroiditis, or with a year of the end of the pregnancy, postpartum subacute thyroiditis, which we also sometimes observe according to diagnosis for hyperthyroidism. So it's routinely, so we estimated TSH as well as T3, T4, and now mostly in everyday practice we use free triiodothyronine and free thyroxine levels. And if the levels are higher, like then you observe in that graph, which is in clamor as the normal levels. So we can say if we suppress TSH lower than 0.5 with elevated T3 or T4, so we can thinking about hyperthyroidism. Patient with milder hyperthyroidism may have elevation T3 or T3 FT3 levels only with suppressed TSH. Subclinical hyperthyroidism features decreased TSH with normal T3, T4, as well FT3 and FT4. The very important story is with antibody and hyperthyroidism. Anti-thyroid peroxidase, anti-TPO antibody elevation we observe in autoimmune thyroid disease in 85% of patients with Graves' disease. Also, in that patient, we observe elevated amount of thyroid stimulating antibody, also known as thyroid stimulating immunoglobulin, a long-acting thyroid stimulator found in 63 to 81% of patients with Graves' disease. Also, the antibody, anti-TPO and TRAP are a positive test for diagnostic of Graves' basal disease, because sometimes we observe Graves' ophthalmopathy, which elevated TRAP, and the hormones are not so strongly suggesting hyperthyroidism. But the beginning of Graves' disease can be like that. So according to the autoantibody, toxic multinodular goiter show that low or absent anti-TPO and negative TRAP. Toxic adenoma, low or absent anti-TPO and negative TRAP. Patient with active thyroid disease may have mildly positive anti-TPO and TRAP. In cases of subacute thyroiditis, low or absent anti-TPO and negative TRAP can be observed. How thyroid hormones related to female reproductive system? That's an important question, especially for gynecologists. The several mechanisms of action can be suggested. Directly affecting the ovary and endometrium during the luteal phase, as well as the trophoblast and placenta via thyroid hormone receptor. Also in the ovary, thyroid hormone in synergy with FSH stimulate granulosa cell proliferation, inhibited that the apoptosis, increase the expression of luteinizing hormone receptor, and stimulate progesterone production. In the endometrium, during the luteal phase, thyroid hormone affects local cytokine production, angiogenesis, and the activity of local macrophages and natural killer cells, promoting embryo implantation, development of the trophoblast, and then the placenta. Uh, uh, Also, the thyroid hormones can influence reproductive system via influence for secretion of prolactin as well as kisspeptin, which in turn affect pulsatility of gonadotropin-releasing hormone secretion and hypothalamic pituitary gonadal axis function. It can be also suggested that the thyroid hormone can stimulating the synthesis of sex binding hormone binding globulin, which affects the concentration and metabolism of estrogen and androgens. Also, it's very important, especially for IVF procedure, that thyroid hormones strongly influence human oocyte. Expression of the TSH and thyroid hormone receptor was revealed in human oocyte in physiological and non-physiological condition, indicating for direct thyroid hormone action in human ovaries. You must also remember that deionidase transcripts were determined in granulosa cells, suggesting the ability to control local hormone activity through deionidation of thyroxine to triiodothyronine, or to laser extent to reverse triiodothyronine. What kind of hormonal profile we can expect it in patients with hyperthyroidism? We can expect it elevated LH as well as elevated estradiol levels because of testosterone and androstenedione conversion to estradiol and estradiol. And also we can expect it elevated HCBG levels. So, according to hyperthyroidism and reproduction, we can say that menstrual disturbances accompanying thyrotoxicosis has been reported frequently in the past 65% versus 17% in healthy women. It's relatively a big difference. The most observed menstrual alternation are hypomenorrhea or polymenorrhea. Among women with hyperthyroidism, fertility problem occur with a frequency of 5.8%. The prevalence of hyperthyroidism in subfertile women is similar to that in general population. However, most women with hyperthyroidism have preserved ovulation, as demonstrated by endometrial biopsy study. So, what we can say about pregnancy in women with hyperthyroidism. So, this pregnancy for sure is associated very often with risk of maternal, fetal, and neonatal complication, influencing miscarriages and stillbirths, neuronal intellectual impairment of the offspring, neonatal hyperthyroidism, as well as low birth weight. So also we can expect preeclampsia, superimposed preeclampsia, preterm birth, and intensive care unit admission in the mother. So what we can offer our patient, even pregnant woman with hyperthyroidism, what is the optimal treatment? The rare cases of methimazole associated with embryopathy, we must remember, and also the risk of propylothioruracil associated with acute hepatic failure also exist. For that reason, the most important authority recommended starting with dose propylothioruracil 50 to 300 milligram in first trimester and metimazole 5 to 15 milligram, then in second and third trimester. So hyperthyroidism treatment can need, of course, follow up, and it should be continued over 2 weeks. And after euthyroid maintenance, check tests should be continued every 2 to 4 weeks. The combination of levothyroxine with antithyroid drugs is absolutely prohibited. Also, the very important practical information for gynecologists and pregnant mother with hyperthyroidism is breastfeeding. There are no contraindication for breastfeeding in hyperthyroid patient if metimazole dose not exceeds 20 milligram per day or propyluracil 300 milligram per day. The drugs should be taken after breastfeeding, preserving 3 hours break before the next one. That's the whole message. Very, very important. Please remember. So the most important story is, of course, according to thyroid and reproduction, is thyroid autoimmunity. And meta-analysis pulling 4 studies showed that presence of thyroid antibody in euthyroid patient is associated with unexplained infertility. The prevalence of TI is approximately 10%, relatively high. Women with PCOS were found to have an increased prevalence of thyroid autoimmune disease. The possible explanation may be the polymorphism of PCOS-related gene for fibrillin 3 influencing the activity of transforming growth factor, a key regulator of autoimmune tolerance. Together with lower TGF-beta, low vitamin D and high estrogen to progesterone ratio, this factor may be contributed to autoimmunity. So, since late 1990s, several studies have been published on the impact of TI on outcome after HRT. However, the data are very conflicting. In a retrospective study, pregnancy outcome between 114 type positive versus 495 type negative infertile women was compared, and no significant differences in fertilization, implantation, pregnancy rate, live birth rates, or higher risk of miscarriages could be revealed. A positive TI status increases the risk of developing clinical hypothyroidism. Women with TI are the interact risk of developing subclinical hypothyroidism during spontaneous pregnancy. In the case of associated reproductive technology and ovarian hyperstimulation, it has been reported that TSH level increased significantly above 2.5 before pregnancy, and even more so in the presence of TI. Since thyroid hormones play an essential role in oocyte maturation and implantation, it has been hypothesized that the decline in thyroid function induced by the stimulation protocol in women with TI may negatively influence pregnancy rate in HRT. Subclinical hyperthyroidism increases the risk of miscarriages compared to euthyroid women with spontaneous pregnancy. Also, the risk increase with term of absolute events is limited. Recently, Sang and co-workers conducted a meta-analysis of 9 cohort study among women with subclinical hypothyroidism of normal thyroid function before 20 weeks of pregnancy, and women with subclinical hypothyroidism had higher prevalence of miscarriages. In the subgroup analysis influencing 3 study, patients with subclinical thyroid dysfunction had a higher prevalence of miscarriages than euthyroid women. So, according to an intrauterine insemination, in a study by Carmon and co-workers, euteroid patient preconceptional TSH value in the high normal range between 2.5 to 4.9 were not associated with adverse intrauterine insemination outcome in terms of live birth, clinical pregnancy, or spontaneous abortion. A recent retrospective cohort study found that among euteroid women, preconceptional TSH values between 2.5 and 4.9 did not have a negative effect of intrauterine insemination. So, in the end of the day, my recommendation of suggesting on the basis of my long everyday praxis in women diagnosis with fertility problems, evaluation of thyroid function is recommended determination of TSH, anti-TPO, anti-TG concentration. In the case of abnormal TSH concentration, also free thyroid hormones can be recommended. Women with hyperthyroidism and fertility problems should be treated according to the general recommendation for the management of hyperthyroidism in women planning pregnancy or pregnant. Recommendation 3, women with hyperthyroidism had higher prevalence of miscarriages. Optimal therapeutic choice in pregnant women is to starting with dose propylothiol acid 50 to 300 milligram per day, depends of severity of hyperthyroidism in the first trimester, and then we continue metimazole 5 to 15 milligram per day, then in second and third trimester. The recommendation 5, there are no contraindication for breastfeeding in a hyperthyroid patient if metimazole dose not exceed 20 milligram per day or propylothiol acid 300 milligram per day. The drug should be taken after breastfeeding, preserving 3 hours break before the next one. And in the end of the day, so I would like to invite you to Kraków, a beautiful city, where we have one of the oldest university, Jagiellonian University, and that university we organized a well-known conference. I mean, it's a jubileum, it's a 10 conference, 10 years, 20, not 10, 20, 10 conference, Alice or Albert Netter's Day, the most frequent problems in gynecological and obstetric practice, how to solve. We have absolutely brilliant speakers from whole Europe, also from Poland, and we expected a lot of participants. We're waiting for you. Welcome in Kraków. We propose Polish hospitality, and for sure we will have an unforgettable moment if you come to Kraków. Thank you for your attention.
Thank you very much, Andrzej, also for showing us the beautifulness of our next Albernetter Days in Krakow. And thank you for your beautiful presentation on hyperthyroidism. Then now we have opened the discussion, and then we have already received some questions from the floor, and I suggest the people remind you to write your question in question and answer chapter. And thank you. We have Sophie, can you open your microphone? Thank you very much. And we have one question from Ilir Juniku. Thank Professor Christin. Maitre, in cases of normal TSH and high anti-TPO, do you recommend a treatment?
This is a very good question. And the answer is not easy because there are very few randomized trials. There are 3 randomized trials, and 2 of them says there's no need to treat, and 1 says it's a good thing to treat. So therefore, it's hard to have a conclusion. I think having high TPO and antibodies anyway, you need to check for the TSH. And if the TSH is below 2.5, you do not have to treat.
if it's higher than 2.5, ask the patient whether she agrees or not to have a treatment, because there is no real decision that can be taken according to proofs. So many people say thyroid hormone is not an expensive treatment, it's well tolerated, so why not starting a treatment? However, there are a few studies showing that over-treatment might be harmful for the child later on.
Yes.
So this is, as for everything, one should be careful. But measure TSH, and then if it's higher than 2.5, I think you should treat.
Thank you very much. And then now, Andrzej, we have a question for you. Which form of hyperthyroidism has the greatest impact on fertility?
So, in my opinion, according to thyroid autoimmune disease, so the most important influence have Graves' disease for sure, because number of antithyroid levels is increase, and it's one of the risk for miscarriages in comparison to the other form of hyperthyroidism. And according to the first question to Sophie, I must to say that for my everyday practice, in case when my patient have high amount of antibody, of thyroid antibody, so I use it, I check the vitamin D levels, because they present very low vitamin D sometimes, and treatment with vitamin D is depend of severity of the vitamin D deficiency, can help and increase the number of autoimmune titers. So that's my everyday practice, I must to say. It's not in the publication, but for my everyday practice. And I have also a question to Sophie. Could you say, because it's very important, is levothyroxine treatment a contraindication for breastfeeding or not? Because I don't find.
Of course not. Of course not.
Yeah.
You should
Thank you.
continue thyroid treatment during breastfeeding.
Thank you, Sophie. And then now we have a huge question for you from Claude Hughes from Canada. And you know, he published, we mentioned that he published 2 papers that hypothyroidism is linked with the risk of gastroschisis, and then all association of maternal depression and hypothyroidism with effect of gastroschisis. And then he asked you, on the basis of our data from Canada, we argued for universal thyroid screening in pre-pregnancy or as early as possible in pregnancy. What do you think? Does potential reduction of that risk tip the scales?
There's a huge debate about this. It's mainly economical, whether you can check everybody for TSH level. It's a huge amount of money. So is it really reasonable? And this is why many societies, especially the European Thyroid Association and the American Thyroid Association, they actually recommend that it should not be a general test. It should be only to some patients. However, of course, you're always going to find someone who's going to benefit from the treatment, but on a general population point of view, it's not recommended to test everybody. So, of course, you mentioned your study about gastroschisis, but there are other effects. I had a quite short time, and I could not present all the potential impacts. I think, however, that in your study, it was hypothyroidism and not subclinical hypothyroidism, if I'm correct. And but this year in GCM was also published a study looking at children in China after ART and subclinical hypothyroidism. Actually, it had an impact on the 1-year-old child. They communicate less
if their mother had subclinical hypothyroidism. So I think there are a lot of reasonable studies showing an impact. So maybe the American Society of Reproductive Medicine is going to change their idea in 1 year or 2 years from now on. But I think several studies are starting to demonstrate that thyroid hormone could help probably.
Thank you very much. And then Andrzej, Letizia Lanfranchi asked, which level of TSH should I consider pathologic for sure in the first trimester, and when it can be modified by beta-HCG levels? And then later on, at what gestational week should I repeat TSH and consider it reliable?
So we keep its level as TSH lower than 2.5, and then is a second and third trimester. So if it's between 2.5 and 3, it's okay. So
thank you. And then okay, that question from Arlene Feder. Should we follow pregnant patient with hypothyroidism by special pregnancy referral lab, or any general lab should be okay?
Well, I don't know or what is the lab you're using. Actually, it's much easier now than 10 years ago because the references are more, they're now generally used. So the TSH level, nowadays, it's not so difficult to measure TSH as it used to be. What is important in your patient with hypothyroidism before the pregnancy, I did not mention this because it was not quite the topic today, but you should increase their thyroid hormone level by at least 30% at the beginning of pregnancy. So if a woman was on thyroid hormone before the pregnancy, as soon as she's pregnant, you should increase the level by 30%, because during the first trimester, physiologically, a thyroid function increases. And if the woman has Hashimoto's disease, she's not going to be able to increase her T4. And actually in Egyptians, the diagnosis of pregnancy was performed on looking at the size of the neck and looking if the thyroid was increasing, because they didn't have HCG level. They could not measure HCG. So thyroid function increases during the first trimester. So this is very important for brain development of the fetus to have correct T4, maternal T4.
yeah.
Thank you very much. And then Andrzej, we have a question from Raymond Lee. In a woman receiving fertility treatment, if only anti-thyroglobulin but not anti-TPO is raised and the TSH is between 2.5 and 4, should we offer any treatment?
Once more, can you repeat it?
I can answer this because actually nowadays there's no use to measure anti-thyroglobulin levels.
Yeah.
All societies, they recommend to measure only anti-TPO. So the situation should not happen because there's no need to measure anti-thyroglobulin level.
Thank you, Sophie.
Thank you. And then another one for Andrzej. Which drug you mentioned is recommended for hyperthyroidism in pregnant women? You mentioned that there are differences according to the period.
So no, it's a international guides that guidelines that we start in the first trimester with propionate, and in second and third we continue to treatment with metimazole, and dose of these two drugs depends of severity of hyperthyroidism.
Thank you. And Claudia Firpo, Sophie, she asked, thank you for the excellent webinar. Do you recommend any mineral supplement for autoimmune thyroid disease?
According to selenium, probably.
Vitamin D. Vitamin D. Otherwise, it's quite difficult to
make sure. I think there are no real randomized trial showing any benefit. But of course, like for instance, in France, every woman wishing a pregnancy, she takes vitamin D. Everybody gives her, and we do not measure anymore vitamin D, blood levels of vitamin D, because everybody is lacking vitamin D anyway. So we give a lot of vitamin D, that's for sure. And other minerals, well, an important thing is that women taking iron, they should not take their hormone, the thyroid hormone level within half an hour. I mean, women taking iron, it decreases the absorption of thyroid hormone. So it's very important not to give at the same time the thyroid hormone and the iron. That's an important issue, because sometimes it creates high TSH just by interference between iron and hormone and thyroid hormone. Another thing is biotin. Biotin it's very important for you to ask if the woman is taking biotin, because it might interfere in the level of TSH and T4.
Okay.
Like for instance, I'm gonna give you this example. I had a patient, she was taking thyroid hormone, she was pregnant, her TSH was 2, and so you should follow them every month or every at least 6 weeks. And she sent me and her TSH was 50. So I was amazed. And in fact, it was because she was taking biotin, and biotin is interfering. So this is a very important question to ask your patient, whether they're taking this type of vitamin with biotin.
Sophie, what
Thank
do you
you.
think about
And then-
selenium? About selenium.
Oh, yeah. Well, selenium is more for eye disease in Graves' disease, but
Yeah.
And
this is the indication.
thank you, Andrzej. And then, Andrzej, for you, can you breastfeed during treatment for hyperthyroidism?
Yeah, so of course, absolutely, but it's depend of high the dose of drugs is limited. If you would like to continue breastfeeding, so the concentration, as I mentioned in my presentation, methimazole dose can be not higher than 20 milligram, and propylethiouracil higher than 300 milligram per day. So then, and also what is important, so that we must preserving 3 hours before the next one breastfeeding.
And then also another question for you, Sophie. If biological FT4 increase is in the morning, then iron should be taken in the afternoon?
It could be taken at noon.
Yeah.
Yes. No, this is a very practical suggestion. And then another one, how often a woman on thyroid hormone treatment should be tested during her pregnancy?
So at least, it depends if she has other measurements to perform.
At least every 6 weeks. And then you adjust the treatment according to your TSH level.
Thank you. And then for you, Andrzej, from Raymond Lee, if a woman is found to have raised TSH at pre-pregnancy screening, should we routinely recheck before starting T4 replacement?
Yeah, of course. Yes.
Well,
Okay.
it depends the level. If it's the TSH is 50, you treat right away. But if it's 4.5, then you can check. Depends on the level.
Yeah, absolutely.
No. And then, first of all, I would like to thank you for your presence. We have received messages of thanking you from Kosovo, from Argentina, from Brazil, from all over the world. And then I would like, at the end now, would like to ask you to give your final comment. You know, subclinical hypothyroidism in one side, and also I would like to send subclinical hyperthyroidism, because, you know, we have hyperthyroidism with then I would like first we will ask Sophie. Sophie, can you give your final advice on the importance, mostly for gynecologists and obstetrician, to test for subclinical hyperthyroidism?
The first thing is that every woman you see, you should think thyroid. This is the first issue. And then probably in many cases, you're going to measure TSH. If it's higher than 4, you can treat her or send her to an endocrinologist and work together. That's a very important issue. And of course, you should not leave a woman with a TSH level higher than 4 milli-IUs per liter. In any case, and especially if she wishes a pregnancy and if she's infertile.
Thank you very much. And also I would like to that we have to follow the suggestion of Sophie Christin at any age of the woman. Today we are speaking about pregnancy. I am taking care of the menopause, and also in menopause, following the woman, always we have to screen TSH. And now, Andrzej, your last word on the subclinical hyperthyroidism.
According to highest subclinical hyperthyroidism, it should be the same story. So we observe the patients, we observe TSH, how it's changed, we observe the title of antibody. So if it's increased, so we start with treatment. If we scan is still not severe, so we can, I think that the treatment is not necessary to start immediately. So so we must be patient. And we observe the patient, and it depends of activity of this subclinical hyperthyroidism. So we make a decision that, okay, so we start to treat.
Thank you. And then, dear friends, you have followed what Sophie and what Andrzej they were telling us. It's very important, the collaboration between gynecologists and endocrinologists.
Yeah.
That collaboration is for any moment. You have to think about early childhood till the advanced menopause time and elderly age in women. Thyroid have to be checked, evaluated. We have huge possibility of treatment, huge possibility of to correct the situation, who can increase the total life risk of the woman, the total life risk of the adolescents, of fertile women, of pregnancy, and so on. Then, dear friends, thanks very much, Sophie. Thanks for your time, for your devotion to the European Society of Gynecology. Thank Andrzej Milewicz for your help, your activity, and your development of the next event in Krakow for the Albernetter Days. And also, now we will announce the next event of our webinar of European Society of Gynecology will be in September. And we have to jump out of the summertime, the beginning of September, the 3rd of September, till Professor Andrzej Milewicz and Professor Alfred Mück from Germany will speak about menopause tailored therapies. Thank you very much to everybody. I hope that you will be with us. Sophie, thank you again. And this is our beautiful next Congress in Riga next year, March 1922. It will be a fantastic Congress of the European Society of Gynecology. We are waiting all of you here. Thank you very much, dear friends.
Thank you.
Thank you, Sophie.
Bye.
Andrzej. Bye. Bye.
Have a nice holiday. Bye.